The health and medical information provided during this webinar, as well as the questions and responses from the webinar providers, are solely for informational purposes. This content is not intended to take the place of advice or treatment from health professionals. Nothing presented in the webinar is intended to be used for medical evaluation, diagnosis, or treatment. It is not intended to substitute for your relationships with your own healthcare and pharmaceutical providers. Always seek the advice of your healthcare provider before beginning any new treatment, or if you have questions regarding a medical condition.
Welcome, everybody. My name is Anand Shridharani. Like you said, I'm a urologist. I practice in Chattanooga, Tennessee, and I've devoted my career to the practice of men's health. That's both medicine and surgery. I've been in the Chattanooga area for about 12 years now, since I went through fellowship. I did my fellowship in men's health, andrology, and reproductive medicine, as well as prostatic urology, which we'll actually be covering today. But I want to congratulate you all for being here. It takes a lot to go through some of the situations that can occur after prostate cancer care, and to stand up for yourself and the symptoms that you may have afterwards and really try to figure out what's going on with them. This is a very niche field within urology, and not many urologists actually take care of some of these issues. So I'm glad that I can offer you some information today and hopefully allay some concerns and potentially offer you some information that you may use to your benefit and quality of care. One of the reasons I went into this particular field was with my own parents. My father's struggle with cancer and the quality of life issues he has are similar to the ones that we'll discuss today. So I've held this quite in my heart for a long time, and it's very important to me. And I felt that men initially, a decade ago or more, really didn't have great mentors and direction with regards to their care. And I feel as time has gone by and more practitioners care about men's health, that we can offer a way for men to improve their quality of life more so than prior. So that's what I'm here to talk about today, specifically cancer survivorship. Cancer survivorship involves what you have to deal with after you get diagnosed with prostate cancer. So you're automatically a survivor the day you get diagnosed, and then you may or may not undergo primary treatment for your prostate cancer, and then you may have some issues associated with the treatment that we will discuss today. So thank you again for being here, and hopefully you find this informative. So what we'll be talking about in general is life after prostate cancer, during prostate cancer, and all around. We'll take this from a perspective of what men will deal with, but we have to take into account your loved ones in the situation, specifically your partners, who have to help you and support you along the way. And sometimes it can feel like a helpless situation if you try to struggle alone with some of these issues. So it's really important that you engage with partners if you have them, and tell them what you're feeling, and have everyone be an advocate and support you through the prostate cancer care treatment spectrum. We'll first talk about urinary incontinence, which is essentially leaking urine uncontrollably, and that tends to be the most bothersome complaint, especially after you have a radical prostatectomy or primary treatment for prostate cancer. We'll discuss what it is, what the causes are, and what the potential treatment options are. And then we'll do the same thing with erectile dysfunction. We'll discuss what erectile dysfunction is, what potential treatment options are, what we can do to improve quality of life. And then we're lucky to have John and Betty Douglas today, who I've worked with in the past, who have undergone prostate cancer treatment and have gone through all the different types of treatments. And their story is really impactful. And I hope you benefit from it, because they're a blessing to see them and hear their story. And some of you might emotionally connect with what they have to say. So it's great that we have them here to talk to you today. Life after prostate cancer, what we talk about and what we see mostly in our clinic and our patients is that prostate cancer is extremely common. It's about 1 in 6 to 8 men will get diagnosed with prostate cancer within their lifetime. It is the most common solid form of cancer, that solid organ cancer that men will get. And whether you receive treatment or not, there are definitely implications how it can affect your quality of life, again, and the people around you. It doesn't necessarily mean if you have prostate cancer that you will actually get treatment. Some low-grade prostate cancers, you may go on active surveillance, wait a few years, follow your PSA levels, and then get rebiopsied, and then have prostate cancer to get treated, or you may not ever get prostate cancer treatment besides just watching it. There are plenty of different treatment options. There's about 5 to 10 now. There's removal of the prostate there is radiation, there's ultrasound, there's different modalities of radiation. There's seeds, there's external beam radiation, each one having its own ability to affect the nerves and continence mechanisms around them, depending on what the treatment is. For radical prostatectomy, which is the most common form of primary treatment for prostate cancer, many men will experience leakage to differing degrees, either because of the prostate cancer treatment or by having some issues associated with it, enlarged prostate prior. Even men who have undergone radiation therapy may experience some leakage. We'll talk a little bit about that. And the thing is, what we as practitioners who care about men's health and cancer survivorship focus on is that men are essentially unhappy. There is plenty of men that we don't necessarily engage that well as a medical community. And we're here to address those concerns and understand that people may be dissatisfied with the certain conditions they get after having prostate cancer treatment. And so men can be unhappy, and I think information plays a lot, but also what are the treatment options? Then we allow men to make decisions if they want to go through with things that would improve their quality of life, whether they want or not. It ultimately ends up being a quality of life decision for them and their partner. So we'll give you information about that. After prostate cancer treatment, when you remove the prostate, it directly affects the nerves and the blood flow to the sphincter muscle, which controls continence and the erections. Ultimately, when you remove the prostate, you're taking a section out of the lower urinary tract out. You have your bladder that empties through your prostate into the urethra, and you're essentially removing the prostate, which only leaves the sphincter below the prostate. So most commonly, men will leak after the procedure, and they can have the best surgeon around, and you still will have leakage. Whether one gets urinary incontinence has to do with how good their prostate cancer surgeon is, but additionally, it has to do with their anatomy, their medical conditions, how well they heal. So there's multiple different reasons why someone would experience incontinence. But when you do experience incontinence right after prostate surgery, most people will have an ability to recover some of that over time. With radiation, when you get radiation to the area of the prostate, it can affect the nerves and the sphincter surrounding the prostate. And most times men will experience issues with incontinence or erectile dysfunction over time. You may not have side effects related to radiation initially with regards to incontinence and erectile dysfunction, but they may develop over time. Whereas prostatectomy, you may get those issues up front and possibly recover from them. So 1 in 3 men will experience a significant amount of urinary leakage after they get their prostate out. And usually these men will recover over time. The issue is that you need to make sure that you are being followed for it. If you're bothered by it, you need to have solution options just to know, hey, am I going to leak forever? Am I going to leak for a little bit? Where am I on the spectrum related to other patients? That information is really important. And understand that if you are unhappy with your level of urinary leakage, it's very treatable. And the options there, even though some of them may be surgical, and you may say to yourself, hey, I had a surgery and now I need another surgery. That can be a lot of information that you may just not be interested in. But the ultimate thing is that it can be fixed. And where I practice, we've developed a cancer survivorship program to allay some of these concerns. We actually see people before they actually get their prostate cancer procedures. We discuss erectile dysfunction and incontinence, among other things that may happen after the prostate cancer procedure. And usually that information, once they get before the prostate cancer surgery, it allows them to not be as helpless during that time. Some of you, after your prostate procedures, you may say like, well, I didn't really get any options for how I'm supposed to manage this. Is this normal? Is this something that I should be expecting? Am I improving like I should? Sometimes being at home by yourself and struggling with leakage, you just want to know where you're at. Am I going to get any better? And information will help that, because sometimes you will just take some time to improve your incontinence, but sometimes you won't, and you want to know that information to help you. Erectile dysfunction after prostatectomy and radiation is extremely common. Half of men will experience erectile dysfunction if they have good erections prior to the prostate cancer. And that time to recover your erection is about 18 months in general. And that's a long time. And if you're not leaking anymore and you want to re-engage with your partner intimacy and have erections good for sex, you may not want to wait that long. So there are treatment options. Usually we do recommend some treatment options right off the bat after prostate removal to help blood flow as part of rehabilitation pathways for your blood and your nerves. But sometimes people don't get there with pills, and so there are other options out there. With radiation, on the other hand, you may not experience erectile issues initially. It may take some time for that to develop. Also, as you age, you may have other medical issues that lead to erectile dysfunction. Really, the treatments are essentially the same, whether you have radiation or prostate procedures. The treatment options for erectile dysfunction haven't really changed that much. You see a whole bunch of things online that are kind of mixes of already existing erectile dysfunction treatments that kind of package things up and put it at a higher cost, and then you go and get them and they don't really work any better. There is plenty of information out there what the tried and true options are. And so it's just up to you to say, like, well, I'm unhappy with the way things are and medications don't work. What's the next step? And if the other steps don't work, what is the final step? And all that information, again, should be given to you by some practitioner that cares about doing that. She takes care of all different types of sexual medicine. So when we think about how the urinary system works as a basis for understanding why urinary incontinence occurs, you have to understand a little bit about what your body is doing. So usually when your bladder gets filled, your brain sends a signal for your sphincter to relax and then your bladder to squeeze. And so you need that coordination. You need your sphincter to relax. That means your valve needs to open and your bladder, which is essentially a pump, needs to contract. And so your sphincter, your valve will stay open as your bladder fully contracts. And then once it's senses that it's empty, then your sphincter closes back up again. And that sphincter muscle is essentially the main way that both men and women have control of their urinary leakage. The male sphincter is a little bit longer. It includes the prostate in that complex. So usually men require their prostate and their sphincter in total, which includes your bladder neck, to actually hold urine in. And so when you are surgically changed, when you remove that portion of that valve, you can leak. But over time, with strengthening your sphincter, either through exercises or other options, or just time, you may regain control of your urinary incontinence. So you can see here is a diagram of showing that the bladder neck, prostate, and sphincter are together in a normal prostate. And once it's removed, you can see that funneling changes, and really that external urethral sphincter becomes the main structure that is allowed to hold urine in and control that urine. So how much length of the urethra your surgeon preserves or you have when you're getting a prostatectomy, that directly relates to how well you'll be able to hold your urinary incontinence, as well as preservation of the nerve fibers surrounding the prostate. Sometimes when you have bad disease, if you have high-risk disease, you may have your nerves resected, and that lowers your chance of regaining urinary control. That lowers your chance of regaining erectile function. So it's important to understand what your surgeon says afterwards. Were you able to save the nerves? Were you not able to save the nerves? Because when you're surgically changed, those nerve signals that go to your sphincter muscle will help them recover. How quickly they regrow, and how much tension or traction forces were on those nerves at the time of the prostate procedure can also affect how quickly your recovery is. So we discussed, prostate cancer is a very common cancer that men will have. It ranges from being very minor to not requiring treatment to being severe and having what's called metastasis, where it can spread outside your prostate, spread to your bone, your liver, other brain, other different organs, and you can get pretty sick from this. What your primary treatment is will be based on what degree or risk stratification your prostate cancer is in. And so there are plenty of men dealing with this, and how you deal with that prostate cancer is really a discussion between you and your urologist. In addition to radiation oncologist and medical oncologist, the nice thing about prostate cancer treatment today is that it should involve many different specialties, and then you can choose what's best for you. But ultimately, the side effects are relatively similar, occurring at different timelines after the primary treatment. So that when we focus on urinary incontinence is the unintentional loss of urine. So it's not when you want to go to the bathroom, it's occurring at any given time. You could be lifting a grandchild, you can be working out in the yard, you can be at a meeting giving a discussion and you leak, and it can be in very embarrassing times. Some of these things can lead to shunning away from social activity and feelings of depression and shame. And that's why social continence and social incontinence putting life to how much leakage you have is really important on how you view your transition through the prostate cancer treatment pathway and how you look at how you should go about treating it. So when that sphincter is too weak, you will leak. Over time, you will recover that control for most people, but there's still a significant percentage of men who will have continued leakage. So there's many different types of urinary incontinence. The most common type of incontinence after prostate surgery, that's if you get that a prostate surgery for an enlarged prostate, a TURP, or a laser procedure, you can develop stress incontinence. That's the same one you would get with removal of the prostate for prostate cancer. And these are basically stress-like maneuvers leading to incontinence. Getting up out of a chair or getting out from a truck, lifting heavy objects, coughing, those would all lead to involuntary loss of urine because, again, your control mechanism has essentially been shortened and your sphincter muscle, which is the primary way that you will control urine, has been possibly weakened by the surgery and it will possibly recover over time. That's different than overactive bladder. That's bladder-related leakage rather than sphincter-related leakage. You can develop overactive bladder just from having an enlarged prostate over time. You actually don't have to have a prostate to develop overactive bladder. Women have overactive bladder. That's when you have a strong urge to urinate and you can't control it. And before you get to the bathroom, you leak urine beforehand. Like coffee and tobacco, spicy foods, alcohol, they create that urgency. And then sometimes if that urgency is enough, it can overcome your valve system and then you can leak. Some men who undergo prostatectomy, who had enlarged prostates or who had overactive bladder, may experience both types of urinary leakage. And that's really important to have someone that understands that, because you may undergo procedures to fix your stress incontinence and then still have leakage, and it's not necessarily related to your stress incontinence procedure. It may be because you have overactive bladder, which has to be treated separately. So these two issues of stress and overactive bladder have to be treated separately. And that's when people have mixed urinary incontinence and when they have both types of leakage, both stress and urge related. Overflow incontinence is somewhat rare and uncommon. That's basically when your bladder gets way too filled and it overcomes the pressure that your sphincter and prostate are having there. So just the pressure becomes too great for your bladder to hold and it just completely empties your bladder. That's a different type of incontinence. And usually that occurs with people who have some spinal cord injuries and people who have enlarged prostates who develop retention. That can happen in those situations, but that's not as common for what we deal with after they have prostate cancer therapy. So the number one cause of stress incontinence is prostate surgery. That's, like I said, prostate cancer removal or taking care of your prostate for enlarged prostate with a TURP laser procedure, pull-up. There's multiple ways to take care of that prostate tissue, but during the procedure of either one, either prostate cancer removal or for enlarged prostate, the sphincter is weakened or damaged, and that can lead to urinary leakage afterwards, which most of the time you can have some recovery from. However, there are a whole bunch of other causes that can lead to urinary incontinence, diabetes, stroke, other nerve issues, smoking a lot, but those levels of incontinence associated with those other issues are more likely to be overactive related than to stress. So when we think about incontinence and the management of it, you can either fix the problem or fix the symptom. So the symptom is urinary leakage. What do you do about it? Well, if you plan on having an ability to recover from it, you may not require it being fixed initially. And so the most common thing people will have after they get their prostatectomy is pads. So pads will collect that leakage and you'll have to change them out. You have to use a lot of them or a little of them, or you may not need any at all after prostate cancer treatment. There's clamps, and then there's catheters you put on. Clamps tend to be uncomfortable, but if you have a really high amount of leakage, you may require that. Same thing with a condom catheter, which is basically a condom that goes into a bag and you put it over your penis after the procedure. That urinary leakage can be that significant. None of this is fun. Hopefully these are temporary options prior to getting it treated or recovering on your own. When we think about pelvic floor physical therapy, which is a way for men to strengthen their pelvic floor to improve continence, either before or after their prostate removal, it does do great things. And I recommend it for everybody undergoing prostate cancer surgeries. However, if you look at the men who do pelvic floor exercises against the ones who do not, at the end of a year, when you've recovered from it, there's really no difference in the people who had severe leakage they may leak anyway, regardless of whether they underwent physical therapy. So again, when you have physical therapy, that can quicken the continence recovery after you have your prostate removal. But in the end, if you're going to be a severe leaker and you're leaking a lot, physical therapy may not help. Treatment, on the other hand, rather than management of the symptom, is going towards a solution or something that would help your sphincter function well. So there's multiple options that you can have. There's not on the slide. There's bulking agents, which can improve the strength of the sphincter. That's for low grades of incontinence. That may help. There are surgical options which are more effective. There's adjustable balloon devices that were popularized in Europe, where you can place balloons alongside the urethra that inflate, and then you can adjust the filling of the balloon to achieve your level of continence. There's male slings, which is extremely common for men who deal with mild to moderate levels of urinary incontinence. What is a mild to moderate level of continence? So we kind of use pad weight or pad amount. So if you're between like up to like 4 pads, that's mild to moderate. 4 to 5 pads is moderate. 1 to 2 or 1 to 3 is mild. And why we're not so exacting about that is people have different tolerabilities for how much they leak. Somebody could be wearing a diaper and leak into it all day and it could be soaked, whereas someone would change out their shields or their pads with just a little bit of dampness. So men deal with this differently. So we have to be sort of clever and investigative for finding out how much the leakage is and pick the right solution to do that. Because if you have severe urinary leakage and you're 5, 6, 7, 8 pads or more per day, you may require an artificial urinary sphincter, and that mimics the function of your natural sphincter. It's a little donut that fills up with salt water you place around your urethra, and it has a certain pressure to it. And whenever you want to go to the bathroom, there's a little button that's inside your body in your scrotum that you just press, and it'll relax, and it acts like your sphincter. You urinate, and it closes back up and allows you to hold your urine better. And that's for severe urinary leakage. So when we talk about a common option, which is a male sling, that is something that does not have any moving parts to it. It essentially is a hammock that's used to support your urethra and put it back in a better position. When you have your prostate removed, it alters your anatomy and it changes how your urine flows out, and the back part of the urethra can fall a little bit. And so the sling readjusts your urethra back to a quote unquote like normal position. And allowing that normal position allows you to hold your urine better. It's a long-term solution. There's greater than 3-year data on male slings that show that they're 80 to 90% successful for mild to moderate incontinence. They're relatively easy to recover from, and usually people just have a catheter in overnight or no catheter at all, recover from it just without heavy lifting, and then they are able to have that degree of urinary control going forward. And what this does, not only besides saving money associated with pad use, because the cost can be very significant over time, but it really gets you engaged back in the life that you used to have prior to the prostate procedures. I see a lot of men who sometimes hesitate about taking that next step. Like I said before, you got in this position for having a surgery. Now someone's talking about doing another surgery to fix it, and you're worried, well, what's the complications and what's going to happen after that? What's my recovery going to be? Is it going to work? You have all these different questions, and that's where a specialist comes in to answer those for you. But the idea of being able to go back to your life beforehand and not have those urinary leakage in those situations, potentially embarrassing situations, it's a really nice thing to be able to engage with your family and be active and not have that urinary leakage. And the male sling is a great option for mild to moderate leakage. Usually people just have some soreness around their thighs and have some change in sensation in their scrotum. Those things are just related to the incision. And usually once people heal up, they don't really have much issues after sling. It's an outpatient procedure and relatively easy to undergo. The particular sling that I prefer and is made by Coloplast is the Virtue sling technology. There's a couple different types of urinary slings. There's the Advance XP, which is made by Boston Scientific, and the Virtue Male Sling. They're both good slings. I prefer the Virtue Male Sling because it does two different things. It elevates back to that relatively normal position and also compresses the urethra. Usually after I put this in, I can look inside the urethra. I'm going to find that the urethra is basically compressed for a lot longer than the competitive sling. and therefore I feel like it offers a better long-term solution, as well as it's not placed directly on the urethra itself. There's some complications that can occur when slings are placed directly on the urethra. This one's placed in the muscle overlying the urethra, so it has a little bit less issues with urethral complications, and people like it generally well. I mean, the issue is that they have to be satisfied with it afterwards. If we put these in and their urinary incontinence is not managed, that may be a surgical error in choosing this particular option for you. However, when you do choose the right person, the right degree of urinary leakage, this is a really effective option that people generally do well from. And if urinary incontinence recurs 2, 3, 4 years down the line, it's a really simple procedure to go and put some stitches in the mesh just to tighten up back again, and people go on their way, and it's way less recovery than going around the first time. So midterm, long-term studies have showed this is really effective for managing mild to moderate incontinence, and something that should be considered for some men who are bothered by the urinary incontinence and kind of fit that criteria. Shifting gears, erectile dysfunction. So usually when men have recovery of the urinary control, their next question is, well, when can I have sex again? And if men do have moderate to severe leakage, they're more likely to have erectile dysfunction. Again, this goes back to the nerves going to the prostate, going to the erection to provide it. And if there is issues with the sphincter function because of nerve damage, they're more likely to have some erectile issues as well. So what do we do with erectile dysfunction? So the first thing is, do I have erectile dysfunction? Well, if there's any aberration or movement away from having a normal erection, you kind of have erectile dysfunction. So if you can't get an erection or you can't sustain an erection, you have erectile dysfunction. I talk to many men, and sometimes it's difficult to say whether you have it or not. Again, this is kind of, sometimes it brings men shame to acknowledge that they have issues with their ability to have a good erection, to have sex with their partner. Most people who do deal with sexual medicine understand this and can be caring and sensitive about this issue, because we see so many men dealing with these issues after not just radical prostatectomy, but diabetes, smoking, high blood pressure, strokes, cardiac issues. So many men experience erectile dysfunction, like 50% of men in their 50s, and then 60% in 60s, and so forth. It's very prevalent. Just understand there are treatment options. I mean, you go online, or even if you're watching TV shows now, I mean, depending on what your age group is, something's going to pop up on your screen to try to treat erectile dysfunction, try to get you thinking about it. Maybe more intrusive than you actually want it to be, but you think about that 5-10 years ago, and there was not really much talk about it. There are many things in the direct-to-consumer marketing space which aren't necessarily more effective than you're trying to Viagra, tadalafil, things like that, which I'll get to in a little bit. But be wary of things that are popping up, and if you feel like you're trying to be sold something, you probably are. So if you have erectile dysfunction, which means you're essentially not satisfied with your erectile function, there are treatment options for it. I talked a little bit about this already. What causes erectile dysfunction? Most common question is, is it just because of age? Not necessarily. I mean, if you have arterial disease, the arteries that go to your erection, if over time they are getting clogged, most commonly due to Western diet. We have diets high in fat, carbohydrates, and that leads to deposits in your arteries that go to your penis. That's going to lead to slow blood flow. That's going to lead to less of an erection. And what's important about that is, if you are on the younger side and you didn't have a prostate procedure, or you had erectile dysfunction before your prostate was removed, that may be a sign that you need to get your heart checked out. We know now that people who have erectile dysfunction, especially if they're younger, they may have a higher risk of developing cardiac disease or a heart attack later on. So as soon as someone has erectile dysfunction, especially if they're 30s, 40s, they should see a cardiologist. That being said, there's plenty of disease states that lead to erectile dysfunction as you age. As you age, more diseases may occur. Diabetes being one common one, hypertension or high blood pressure, surgery, if it's on the prostate or rectum or anything in and around the prostate area, will lead to erectile dysfunction. Some of the medications that treat high blood pressure, depression, things like that, will lead to erectile dysfunction and sexual dysfunction. In addition to any sort of trauma to the spinal cord or neurologic issues that may occur or be developed over time, will lead to erectile dysfunction. So plenty of things lead to erectile dysfunction. The the interesting thing is with all the technology that we have, there hasn't been much change in the erectile dysfunction space with regards to the treatments. No matter what the cause of it is, we usually have the same treatments that we've had for 10, 20 years. You'll see many things pop up again online. Most of them don't have long-term data to support their use, and you may end up spending a decent amount out of pocket for them. So just be wary. Sometimes those alternative options work, but they're for a select few patients. And hopefully if you go to a sexual medicine therapist, urologist, usually if they're aware and they do the whole spectrum of ED treatment, they'll probably be able to give you a better idea whether some of those alternative treatments are good for you or not. This is really important, how erectile dysfunction affects you mentally and affects your relationship. So most times when you have erectile dysfunction, you may be in the bedroom, or you may be with your partner or alone. Once that happens, it automatically goes back up here, and you're thinking about it. And you're thinking about it on your drive to work. You're thinking about it on your couch when you're watching TV. You may be holding your partner's hand, and you're thinking about, okay, am I going to get lucky tonight? But what if I can't perform? All that creates stress, and that stress you will bring to you at every time you are undergo a interaction with your partner. Or if you don't have a partner, it may keep you from getting a partner because of the stress of this. So erectile dysfunction is important to treat it, to get you satisfied and feeling confident in yourself, to be able to perform. Otherwise, it may be affecting quality of life. It'll be in your brain all day long when you're doing something that has nothing to do with sex. And so you'd be thinking about it at work, and you may feel shameful when other men talk about what their sex lives are. And so understand that there are treatments for this. And so if you are feeling that you even get depressed from the idea of having erectile dysfunction, it's important to talk to a counselor if you're feeling depressed about it. I often believe that if we treat the erectile dysfunction primarily and it improves, you may have a better feeling about yourself. But there's some men who also have self-esteem issues. You treat the erectile dysfunction, you're still feeling down. And so in those situations, it's important to seek a counselor to talk about your mental health as well. It's also important that you address this with your partner. Often partners I see will say, well, I think it's me, or, there's always this kind of blame issue going on with partners, and it's really nobody's fault. It's usually because of medical issues, or prostate cancer treatment, which we've discussed. And so this is just a part of life. And what needs to happen is you just need to get the right information and move forward. With guys who undergo prostate cancer treatment, and they wait on ED care, what I find a lot is that they'll have penile shortening after these surgeries. And this can be the most impactful thing that men will deal with afterwards. Even if they don't want to have sex, their penis will shorten after getting the prostate out. So it's really important to do things to improve your penile length, as well as get on some ED therapy or some restoration therapy. There are rehabilitation pathways you can do before you even expect to get an erection after your prostate cancer procedure, which I'll talk to you about when I go through the medications. But that's really important to keep that in mind. So if you are bothered about your erectile dysfunction, it's important to talk to a specialist. Going on Google and looking at things online may address some of those concerns, but talking to someone face to face that cares about it, you may get way more information. And I always recommend when seeing my men that they bring their partner in to have a discussion as a unit. Essentially, if you have a partner there, they also have concerns about it. It's also been affecting them. They would like their concerns to be allayed as well. And that can improve intimacy just by doing that. And then you can make a decision whether even treating the erectile dysfunction is important to you or not. So how does erection occur? Well, you see something you like, you feel something you like, those nerve signals go to the erectile cylinders. You have three cylinders within your penis. Two of them are erectile cylinders that sit above your urethra, and there's smooth muscle in there. That muscle is spongy tissue that fills up with blood. So once those nerve impulses hit that spongy tissue, blood starts flowing into it and it expands. And once it expands, there's an outer covering of the erection that gets tense. And when that outer covering gets tense, the blood flow out of the penis gets closed off. So that's how you trap that blood in there to make a hard erection. If you have poor blood flow in, or the outer covering is not allowing that rigidity or that closure of the venous blood leaking out, you can get erectile dysfunction. There's something common that men will get after they get their prostate out, which is called Peyronie's disease. 10% of men in general can get Peyronie's disease. 20% of men after prostatectomy can get Peyronie's disease. Peyronie's disease is an abnormal scar formation that can occur on your penis that leads to venous leak erectile dysfunction. So if you feel a knot on your penis after you have your prostate out, you may have Peyronie's disease. This can lead to shortening. This can lead to curvature. That can lead to deformity. And so find someone if you have this. Don't wait at home, because over time, this can also cause shortening. Shortening is not good. It doesn't do anything for your mental health and your future sexual function. So if you notice things are shorter, get to someone who can help. So the tried and true option is oral medications. So in general, oral medications are 60 to 70% successful for men, all comers. That's not necessarily people who have their prostate out, but all comers taking erectile dysfunction med. It is pretty effective, and it can fail if your ED is a little bit more prolonged. There is a cost associated with it. There's generic medications that are available that work really well. You shouldn't be spending more than $30 a month for a 3-month supply for some of these medications. If you go online, there are all these different mixtures of ED medications of the tried and true ones that potentially can work quicker, that can potentially do better than the tried and true ones. But if you have nerve damage, those ones aren't going to work out that well for you. So take it with a grain of salt. If you try those experimental mixes, if they don't work, that just means you have to move on to the next step if you try them. However, medications usually will work. Right after your prostate comes out, that's not the case. Again, you have to have your nerves regrow. That may take time. So right after your prostate surgery, if you're not having erections and you take the medication that your doctor gives you, don't necessarily expect it to work. Why I give men generic Cialis, which is tadalafil, 5 milligrams a day. I start before they have their prostate out, and I continue it through. That's not necessarily just to give them an erection. It's actually to help with restoration of the blood flow. When you have the nerves on the outside of the prostate damaged, it leads to atrophy of the erectile tissue. If you think about cutting a nerve in your arm, your whole forearm will basically become very weak, and the muscle will go away. Same things that happen to your penis. So what the tadalafil or Viagra will do as you are recovering is provide blood flow to that area so that tissue doesn't atrophy. So that's erectile restoration, not necessarily treatment. So if your doctor gives it to you and you're like, this isn't working for my erections, keep on taking it, because it helps with restoring your ability to have erections. So you're not any shorter or any more scarred than usual. There are multiple different types of pills. I'm a big fan of tadalafil. Viagra or sildenafil is the tried and true one. I like tadalafil because you don't have to plan out sex if you're on it, and you don't have to worry about what you eat with it. Whereas Viagra, you have to take 1 hour before sex. You can't make sure you have to take it without heavy food intake or alcohol or anything like that. Some of the other options, Levitra, Stendra, they're more expensive because they're not generic, but they tend to work quicker. But the more often than not, Viagra and the generic forms of Viagra and tadalafil, Viagra and Cialis are the more common ones that are used because they have generic pills available. They don't provide instant erections. You have to have some foreplay for them to work. And when they are working for you, they're great. They can wax and wane over time. You don't get necessarily used to it. Your erectile dysfunction, if you're still doing the same things that led to have the erectile dysfunction, that may wane over time. There are side effects, and they vary from headache, blue vision, flushing, upset stomach, and muscle ache are more common with tadalafil. But talk to your doctor, and they can kind of find that. So if you have side effects with one, you may not have it with others. You're not supposed to take any of these pills if you're on a nitrate for chest pain, like nitroglycerin, or anything for high blood pressure that's treated with a nitrate. Injections are a second-line option, or how they've been classically stated as second-line options. Usually first-line was considered to be pills. Second-line was supposed to be vacuum injection, suppositories, and penile implants. Right now, it's actually more of a spectrum. If you don't like the idea of pills or you get side effects with it, you can most certainly move on to other options. You just have to ask your doctor to do it. And they'll discuss the side effects with you and do it. Injections, instead of, you're giving you medication directly into your penis, instead of taking a pill by mouth, having it go through your gut, your liver and only being a fraction of what the effective ingredient is by the time it reaches your penis, the injections directly deliver into your penis. And most oftentimes when I talk about injections, people are like, "You want me to do what? You want me to inject something into my penis? You want me to put a needle in there?" The answer is yes. I mean, if some people, they won't be able to do it. They don't like needles. It's not going to happen, and that's fine. But for a lot of men, it is way more effective than pills. It's about 90+% effective. There are multiple different doses you can use and multiple different mixes. So you get it from wholesale, from a pharmacy, such as MedMD. It's really not that expensive. And on average, usually the dose that is sold to you, you can get about 20 injections out of it. There's plenty of things online and men's health shop clinics that you have to be on a subscription and then get access to the medication you're paying for anyway. It's just a whole bunch of excess money spent for something that's relatively cheap. Should be about $5 to $10 a dose if it works for you. So what you do is you put your penis on stretch, you inject it right into the soft tissue of your erection, really back towards the base of your penis, never on the bottom at 6 o'clock because that's your urethra, or 12 o'clock, or that's where your neurovascular bundle is, but just on the sides. It's a very tiny needle. It's a diabetic needle. It's as small as you can get. It's a tiny little owl. You give it yourself and then wait 15, 20 minutes. Then you should have a good solid erection, and we want it to last anywhere between half an hour to an hour. You can get some minor bruising at the injection site. The biggest risk is development of priapism, which is a prolonged erection lasting greater than 4 hours. That's usually because of overdose or people who double up the dose. When we give teaching, so someone should teach you how to use this in their clinic, usually we recommend a low dose and then going home and titrating the dose up just to specify specifically your dose for you. You have to go home and try it and find the right dose for you. And once you do, people are generally happy. And if they're not, there are other options that you can do to help your erectile dysfunction. The other issue that it can cause is Peyronie's disease. By injecting a site, it may lead to scar formation there. That's one of the more common causes of Peyronie's disease. So if that happens or you have Peyronie's disease, I would not recommend giving yourself an injection. Vacuum erection devices, they are basically a silo that you put over your penis and you pump it up. It creates negative pressure, and then you get an erection, and there's usually a ring that comes with it that you put over the base of your penis. It's not necessarily a natural erection. It's a sort of a cold erection. But if you're having borderline erectile function with pills, this may help you over the top, especially if you don't like the option of doing other things. Can get caught in your hair. Sometimes it can alter sensation. And it's just one cost to get this. There's no recurring cost with it. Some people like it. I'm actually not a huge fan for erectile function unless someone has very minor erectile dysfunction. But what I do use it a lot for is penile rehabilitation. We already talked about restoring erections. This is the best option to maintain your penile length after you've undergone prostatectomy. Many of you may know that you felt like you were much shorter after you had your prostate removed. This is a way you can keep your penile length or prevent it from getting any shorter. So putting a vacuum device on your penis 15 minutes a day will stretch your penis out and allow it to prevent that shortening that may occur. Men may lose 1 to 3 to 4 inches if they don't do anything about it, and that's going to be devastating. If you think about your erections before the prostatectomy, if you're having normal erections, every night and every morning you're dreaming, you wake up with an erection in the morning after your prostate removal. That's not happening. So this is a way to mimic that stretching or those calisthenics to keep your penis stretched. So this is a really important option I use in cancer survivorship to maintain penile length after prostate removal. So insertable medications are another option. It's something called mousse. It's like a little piece of rice you insert in the tip of your penis and give it a little rub. And then that's a non-injection way to deliver local medication for the erectile cylinder so that it can get stimulated and have an erection. Unfortunately, it's sometimes on back order and it's difficult to get and cause some burning of urination. I would possibly use it more, but it's sometimes very hard to get. And it can be quite expensive, and to go through the dose titration for it can be expensive. Some people use it, shouldn't hate on it if people like it, but this is probably a little bit less used than other treatment options for me in my clinic. Penile implants are the end all be all if nothing else works, or you're just like, I need something to have an on-demand erection. In my brain, I need this to be fixed. And I need this as soon as possible because just the idea of having erectile dysfunction is impacting my life and my relationship. This ends up being the most satisfying, quickest point A to point B solution. But it is procedure. It is a surgery. And so there are implications with what that is with regards to what happens during the procedure, what the recovery is. Most people that come to see me, if they're sent by someone else for me to do a penile implant procedure, they're all ready to go. They've tried other options. They're frustrated with it, and they want it in as soon as possible. Whereas on the other hand, if I'm the person telling them about these options, either before their prostatectomy or, right afterwards, they can look at me kind of funny, just like when I talk about injections, because you're going to do what are you going to put in me? Like, no, I don't want any of that. There's a lot of myths about penile implants that if you look online, if you talk to people who don't do this procedure a lot, that can lead to, if you don't do this procedure a lot, it can lead to a lot of side effects, difficulty recovery, higher level of complications. If you look for someone who does this a lot, you really can minimize complications, improve satisfaction. And it's really not just about how well you do the surgery. It's about the counseling you receive prior to undergoing the procedure, assessing what your expectations are, and trying to meet those expectations with counseling prior to make you feel like when you get this done, you knew everything that you're going to experience after is going to happen, and you know what you're going to end up with. But it is one of the most satisfactory solutions out there. It is the only long-term solution that you can do, and it's done. It's the only cure for erectile dysfunction. And what it allows is that if you and your partner want to get after it and get intimate, you are ready to go whenever you want. So this implant is two kind of cylinders that are made of silicone. They're very flimsy on the outside, but what they do is they augment your natural erection. It's your penis, it's your erection. You put these in where the spongy tissue is, where the blood was not going that well, and it hooks up to a pump that's located in your scrotum. The pump is the only thing that you actually feel. Everything is within inside you. It's contained. You drop your pants if you're at the gym. Nobody's going to know you have a penile implant in, and you're not going to walk around knowing having this in place, because it just becomes a part of you. It's made out of the same material as a breast implant. So most people who have breast implants won't notice they have one in there when they're walking around. So it's very discreet, and you have immediate control of it. You can control your erection. You can get it as hard as you want. For some relationships, the female partner or male partner they may not want it fully erect. They may want it as changes with age occur. You may not want this, because this thing can get pretty rigid and pretty hard, and it can give you a pretty impressive erection. So it's very nice to have it in your mind. I got something that I can work with. It'll work whenever I want it to, and if I want to have sex, I can do it whenever. And so that actual peace of mind is actually one of the most important parts of this implant procedure. Not just that it'll give you erection, but the knowledge that you never have to worry about it again is really important. So the satisfaction rates for the men undergoing this procedure are extremely high, mainly because their ED is treated. So why the 2% dissatisfaction? Well, a lot of that has to do with expectations and complications. So people who do this a lot, they're not going to, surgeons usually have like a 1 to 2% complication rate. My infection rate is less than 1%. And most people who put in a lot of these will have similar infection rates. So it can get infected. If it gets infected, you have to take it out and put another one back in. That's not very common for people who do it. The device can break. If it breaks, it leaks out salt water. It doesn't do anything bad to you. But those men who are using it and it breaks, they're the first people back in your clinic wanting it to be reimplanted. And again, it lasts for 10, 15 years on average. If it lasts that long and you're sick and you're not using it anymore, it doesn't do anything bad to you. If it leaks out salt water, it doesn't do anything bad to you. There are other bad complications that can occur in rare situations, such as bowel injury, bladder injury, urethral injury. Those are very rare. I have done some of those things in my career. I've done probably over 1,000 of these, but those things occurring are very few and far between, and special instances. And most people who do a lot of these procedures know how to manage those issues if they were to occur. And the nice thing about this is, the partners are very satisfied, because they see that their partner who has the implant, they're satisfied. They're not worried about it anymore. So from a couple's aspect, it can satisfy both partners. And recovering from this procedure is probably the more difficult part of this discussion. Complication rate is low, pain medication use is low, but you will have soreness. It'll be uncomfortable for 2 to 3 weeks. That's not the fun part. The fun part is after you heal up, which most people do fine. Just got to ice it, wear a wrap around it. Some people put a drain in to limit swelling. And then usually around 3, 4, 5 weeks afterwards, depending on the surgeon, you'll start pumping it up. It'll be comfortable for you after you get trained to do it. And then you're off to the races. 6 weeks after you should be having sex, and then you'll have little tiny shooting pains and like just healing things. If any of you have undergone any other procedure anywhere else on your body, you know that the 90% of the recovery is within the first month, and then you just have a little bit to heal up from afterwards. So once people are using it and they can see that they can get a good erection and they don't have to worry about it so much anymore, people are extremely happy. I talked about some of this stuff already. The main thing that you should focus on is that it is a great treatment option and it fixes ED. Now, there's other implants that you can put in. There's a Genesis implant. It's a bend up, bend down solution. It's sort of like a Gumby penis. That sounds kind of funny, but for men who don't have good control of their hands or can't use the pump well, this is a really nice solution for it. There are other special instances where I use malleable implants that are more comfortable, some of the spinal cord injury or something like that, and they still want to have sex with their partner. These are a good option. These aren't the most common option for men in the United States treating their erectile dysfunction. About 99% of the time, they're putting in inflatable penile implants. There's 1%, but if you look worldwide, actually, these are more common worldwide than the inflatables. And it's usually a cost issue that, luckily in this country, our healthcare system allows coverage for the inflatable, which is more expensive. So I talked about some of these risks already. The big thing about the risk is understanding specific to you, your anatomy. Your surgeon will go through these things with you, what things you are at higher risk for, what things you are lesser risk for. The incorrect sizing issue, size is a really big part of the discussion to be had before the actual procedure is performed. You aren't going to be any longer than you are on the day of the penile implant procedure. So the longer you wait, especially after radical prostatectomy, you may lose length. So if you're using vacuum devices, that's great. That'll keep your length. However, some men, they'll get this option from me or other surgeons, and they'll wait 1, 2, 3 years, kind of hedging, not wanting to undergo the procedure because honestly, they're scared, which is natural to be scared about undergoing a procedure, especially down in that sensitive area. The potential risk of that is that you will lose length. And then when you go undergo the procedure, you're not as long as you were before. It's very uncommon that you were the same length you were prior to the prostatectomy or when you were, 18, 19. Everybody thinks that, their penis is the size of when they were 18 years old, and that's what they have in their head. And everybody wants to get back to that. The thing is, it takes work to do that, even to get close to that, especially after prostatectomy. So the counseling I give my men is, use the vacuum device or there's traction therapy devices you can use to get as much length back before you undergo the implant procedure, and then just to improve satisfaction, because some men, they lose length. They're just like, it's not even worth it to have erection because I've lost some length. And that's just really, that's a sad instance that they have to give that up. And sometimes I feel like they didn't get the right counseling around the time of their prostate procedure. Again, have that discussion with your prostate surgeon, your sexual medicine therapist. When you go to someone to seek someone out to have discussions of all these issues, they should be able to do all these different things and then not necessarily push you to do something, but steer you in the right way depending on what your risk factors are. Some people are not healthy enough to undergo surgery. Some people, who have Peyronie's disease, they can't get injections, so they should skip that section. Some people have been trying medications over and over again and they don't work. Some people have tried shockwave therapy, stem cells, and all the other alternative ones, and they're looking for something that's alternatively based, but unfortunately their erectile dysfunction is too far gone to have any of those other things work. And some erectile dysfunction specialists will use other ways to diagnose blood flow issues like penile Doppler ultrasound, which we do in our clinic. So there's certain ways to get around this and navigate this process. You just have to have someone who cares. And, it's hard to find someone who knows about all these things online. I mean, there's a few of us that have videos online, surgeons that have videos online that are great to educate y'all on where to go, who to seek out, but that may be far for you. There may be resource issues for even to getting to some of these people who do these procedures a lot. There is a hack to do this. If you go on the website, if you go on coloplast.com, there are centers of excellence that do this procedure, and you may find someone who does this locally for you. Okay, so utilize Coloplast website, the MenMD website. You are able to be hooked up with physicians who care about sexual medicine and navigate this with you, and not necessarily try to push you to do something that you don't feel comfortable with, or that may not work and then charge you a lot for it. These things are meant to be cost-effective solutions that will get you from point A to point B, so you can just get back to living life. That's the whole point of why we're doing all this all here is to, control urinary leakage, control ED to the level that you want it. If you're done having sex, okay, you don't need to do any erectile dysfunction therapy. If you're satisfied with leakage and you're wearing 1 to 2 pads and you're like, I don't want to do surgery, that's fine. The issue is being armed with the right information so you can make a decision for you and your loved one that you guys feel comfortable with. And you can always change your mind later. The key is specifically for erectile dysfunction, if you don't do anything about it and consider something later, you may lose erectile length during that time. So it's important to get a vacuum device or traction therapy device. Use that every now and then, or use it as much as possible to keep what you got, so you don't lose it. Once people, make the decision where they want to undergo a penile implant procedure, the next question is always like, what insurance is my insurance cover it? For the most part, Medicare does cover it, which is great. The VA covers it, and then for private insurers, it's sort of a mixed bag. Unfortunately, there are plenty of carriers that will have what's called men's health care exclusions, and that's kind of sucks that they call it like you sign up for this, or your employer signs up for this, and they just won't cover anything for men's health, period. That's not testosterone, that's ED management, everything. They usually will cover incontinence care, but for sexual function, they will not do that. And so sometimes you have to change insurances. Sometimes you have to pay out of pocket for it. And those pay out of pocket prices usually are posted somewhere online. We have some of those costs on our online website. But it's not cheap. So, but if you think about, if your car is junk and you want to buy a new one or it's not working anymore, driving a car is really important to your life. For some reason, for some men, sex is really important in life. It's about the same cost. I mean, for a very cheap car, it's about anywhere between $12,000 and $20,000. It's not cheap in general, but compared to a car cost, it may be. So, it's really important that you have this discussion. Again, going on the Coloplast website, you can find surgeons that do this procedure a lot, and most of them will be willing to help you. Some do telehealth, like I do telehealth visits for Georgia, Alabama, North Carolina, and the state of Tennessee, which I practice, and I'll meet people online just to get that process going, whether or not I operate on them. Sometimes I just give them information, and I can usually suggest someone locally that they can see that they can get their care there. Unfortunately, telehealth may or may not be going away tonight. Today is September 30th. Hopefully, our Congress and Senate pass something where we can continue to do telehealth procedures. That way, we improve access to care for some of these issues that you guys may be struggling with. But that's a separate discussion. Again, I thank you all for listening. We'll get to some questions later. Next, we'll have our patient educator, John and Betty Douglas, to share their story. Again, it's grateful to have them, and thank you for listening.
Good evening. We appreciate the opportunity to come and share with you tonight. I want to share our story, and we do feel strongly that it is our story. While I was the guy that was had the radical prostatectomy and was experiencing the issue, it's obviously a couple's issue. Can't get around that. But what I'd like to do is just to give you a little bit of background about what led up to my having the surgery, and then I'm going to pause halfway through and let Betty share kind of what was going on from her perspective. But the story actually began in March of 1994 when I sat across from my urologist, and he said, "John, I'm sorry to tell you, but you got prostate cancer." Now, at that point, I was 51 years old. I'm 83 today. But at that point, relatively young. So the decision was made to have the radical prostatectomy, remove the prostate. And if I was older, then they probably would have looked at some of the other options. But the first thing we did was try these other options. Now, this was in 1994. And that was well before Viagra. Viagra didn't come out in 1998. So I don't know whether that would have ever helped or not. But I began with the vacuum erection device that you saw, which was the big tube that goes over the penis. And I tried that. And there are a lot of guys that swear by it and use it. And it's wonderful. It hurt like the dickens for me. It was pulling skin and pubic hair, and it didn't work. So I went back and I said, "Doc, what else you got?" And he said, "Well, I got these shots." we can give you a shot. And after I got over the injury to personal, you want me to put the needle where? We tried it, and we tried it several times, but it only gave me kind of a half erection. Maybe the mix was not correct. I'm not sure, but that just didn't work. So I went back yet again and said, Doc, what else you got in your bag of tricks? Because this is not working. At which point we were introduced to the penile implant. And a year after the surgery, it was actually in June of '95, I had the penile implant. So I've had this penile implant now for 30 years. It's the same one. We've never had any issues or any problem with it. So I want to take you through the whole thing, but I'm going to pause here and let Betty tell you what was kind of going on from her perspective while we were going through this issue.
Okay. First of all, I want to thank you for being with us tonight. When we went through that, they didn't have any groups, face-to-face groups or online groups. And so it was really difficult. And if we can do anything, we found a good answer for us. And if we can do anything to keep people from going through it the way we did, we would like to do that. So that's the reason we participate in this. During this time, it was very, very lonely for me because John was the one going to the doctor. I even asked to go with him once, and because the doctor wasn't used to working with the couple, he just worked with the man at the time. That was not real satisfactory even. Although he was the one that got us in, he asked us to meet with couples. He had realized that needed to be. So that made it, even going to him didn't help me a whole lot. I still felt like I was really in the dark. And as we went through it, I don't know whether it was a personality thing or whether it was a man-woman thing, but John was like, if I can sit in my chair long enough, I'm going to figure this out, and I do not want to talk about this. And in my case, when I work through any kind of situation in life, I do better if I have somebody to talk to. So I couldn't talk to him. The doctors weren't talking to me. And I really cared about, it was John's issue. I knew it was really difficult for him. And I really wanted to support him and help him. And so I was not going to talk to my girlfriends, which is what, if I had some other problem, I could go talk to them. And so I felt very alone. And I just don't want that for anybody. So I really like what the doctor said about getting the support, going in together, getting the counseling. It really makes a difference. One of the things I want to say is that the relationship that we have as a couple is different than any relationship that we have with anybody else. We have some really good friends, and hopefully we're best friends with each other. But the sexual relationship is the most intimate part and different from any other relationship we have. So I really recommend that if there's any way to keep that would happen. And so we found out that what the doctors described was very successful for us and gave us back our relationship, our sexual relationship that we thought was gone. Now, one thing that I think recommends anything is if you have something and something happens to it, that you would go get another one just like it. And I used my car to kind of explain that because I had a convertible, and I had said that on a lot of talks, that if anything happened to my convertible, I was going to get another one just like it. Well, something did happen, and they were wanting to total it, and I said, no, we will fix this car because I want to keep it. Well, the thing about this procedure is that the first time I shared this, I hadn't even talked with John, but I pretty well knew that it was true, that if anything were to happen, nothing has, but if anything were to happen, that we would be right in the very next day and get it fixed or get another one if that's what it took. Means that much to us and is that successful. So I think that's most of it.
Okay, great. Thank you, dear. Let me pick back up with the story. So I'm going back to the doctor, and what prompted this was that my PSA was at a 2, and it went to a 4, and within 6 months it went to a 10. So he did a biopsy, and we decided to have the implant. And the incision in those days was much longer. I got like a 5-inch incision across my lower abdomen. But right now, the doctors normally use about an inch, inch and a half incision, usually underneath the penis around the scrotum sac, and even the scar is not visible. You saw the diagram on the screen. Let me just talk you through that about what an implant really is. First, you start with a reservoir, which goes up into the abdomen in the general area where prostate is, and it's full of saline solution, salt water. As the doctor said, if it were to leak, it's not going to hurt you. It's not 35 years ago when the women's breast implant saline situation. It wouldn't hurt you. Anyway, the saline is in the reservoir. There's a tube that goes down to a pump, and the pump is actually placed inside the scrotum. And when the doctor first told me where it was going to put it, I thought, oh, great. Every time I cross my legs, I'm going to have an issue. But it gets out of the way. I've gotten out of the way for 30 years. I don't know how it does, but it gets out of the way. But on the end of that pump, which is about half the size of your thumb, on one end of it, there's a bulb that you pump, and it pulls the saline solution down through this pump and into what I call long skinny balloons. They're cylinders that go on either side of the penis, and it fills up with the saline solution. It gives you a good, firm, hard erection that's going to stay hard as long as you and your partner want it to stay hard. When it comes time to let it back down, there's a release valve. You press the other side of the little pump, and it goes right back down. It takes me maybe 30 seconds to pump it up and about 15 seconds to let it down. A lot of the questions we've had over the years from talking to people, let me just go ahead and try to answer some of those. First question I normally get is, do you know what's in there? Well, no, you don't. After a few days, it just becomes a part of your anatomy, and it's there. You're not even aware of it until you're ready to use it. And then, as the doctor said, that's the only thing you really feel is the pump in the back of the scrotum sac. Next question I get is, what about sensitivity? Sensitivity is exactly the same. The nerves that affect the prostate are different than the nerves that are on the exterior of the penis, and so the sensitivity is the same. What about orgasm? Orgasm's the same. Now, if you don't have a prostate, nothing comes out, but you still get the feeling, the good satisfaction and the contractions. If you've got a prostate, you can still have the implant put in without having to take the prostate out. It's not an either-or situation. There's the doctor mentioned this too, but a lot of people have a hard time understanding the fact that it's completely hidden. It's all inside your body. So you walk around the locker room and nobody knows you got it there. If you want to pump it up halfway and walk around, that's up to you. But it's completely inside and is not visible at all. Let me mention though a couple other things. Number one, Betty referred to this as me being withdrawn. I refer to all this as like psychological overtones that affect your self-confidence and your self-esteem, etc. But it affected me, and I withdrew. Now, I withdrew not only physically, I withdrew mentally and psychologically. I no longer was giving her hugs. I no longer was giving her a kiss. I was no longer patting her on the bottom like I normally do to show how much I cared for her and express my desire to be with her. And why? Because if I did that, I didn't want to start something I couldn't finish. So I withdrew, and it was as Betty said, it was a difficult time, and it has proven to be, once I got the implant, everything changed. And as I close, I want to tell you one story that kind of maybe summarizes all this. This was several years ago. I got a phone call one day And from this gentleman, he said, John, you probably don't remember me, but I was in a group you spoke to up here in Raleigh, North Carolina. And after hearing the presentation and talking to the doctor, I decided to have the implant. And he said, I had the implant put in yesterday. And he's calling me and he says, this is the first time in 15 years I have really felt like a man. He hadn't even pumped it up yet. But the psychological part, knowing that he could have an erection. And again, understand this is only providing an erection. It has nothing to do with the libido. You got to have a desire to do this. This is really just providing the implant. And the doctor referred to this in a few minutes ago about satisfaction rates. I also want to quote another statistic that urology is a specialty, but being able to put in these implants is kind of a subspecialty, and only about 7% of the urologists nationwide do these and do them often enough to be considered proficient at it. So if you decide you want to do this, I would recommend that you go on the Coloplast website and look for people who do this, because if you have somebody that does it a lot, the outcome is going to be much more favorable. We appreciate being with you tonight, and at this point, I think if the doctor's still around, we can jointly answer some questions.
Yeah, that'd be great. You actually covered a handful of questions that we did have, so I have one for you, John and Betty, to answer. I think you might have covered it, but like exactly how long do you think it took for your intimacy to return after you finally found this treatment that worked?
Well, psychologically, it almost immediately, certainly within a few days. But as the doctor mentioned, my doctor used to use the phrase, you got to wait about 6 weeks before you take it out for a test ride. And so it was about 6 weeks before we actually put it to use.
And I think for people, some people listening to that could feel like that 6 weeks is a long time, but we had been through a year before. You didn't even tell the part about waiting for the 6 weeks, but we had been through a year not knowing that there was not us not knowing, the doctor knew, us not really understanding that there was something that they could do. So the year was what was so long. Once we got to the surgery, understood what it was going to be like, the 6 weeks didn't even seem that long. And also getting back some of the relationship already just having the surgery.
What surprised you the most about life with an implant?
I'll start since he's hesitating. I just think for us at the time, because we didn't have any of what you're getting right now, I was just shocked that there was such a thing, and that it really gave us what I thought was gone. I mean, and losing it when we're both the same age, so losing it at 51 was difficult, very difficult.
And the great part is, 30 years later, it's still working, and it's even though the doctor said there's a general lifespan, they've actually got a lifetime warranty on these things, and so I guess I've been pleased with the fact that I hadn't had to go back for a year.
Yeah, very amazing. Well, thank you very much, both of you, for taking the time to share your story and answer those questions. We definitely appreciate that for sure. It's a good review question here. So if all goes well, how long after surgery, prostate removal surgery, would you expect a full erection recovery? I guess there's kind of two surgeries in there, but.
And what can you expect as far as a timeline for erectile function recovery? It just really depends. And I would actually say that that's not the point, is when should I expect it to come back? When you want to have sex after your prostate cancer procedure is the time you should be able to have sex. So and usually it's your urinary leakage is almost gone or gone all the way, and you're like, okay, now's the time. We've been waiting too long. Let's get back at it. Do the pills. Pills don't work. Consider the injections. Consider the implant. Usually Usually for an implant, I will wait a little bit longer unless someone's like, I need to get this done and my life depends on it. You know, my relationship is not going to actually survive this issue. There's some relationships that a lot of the definition of their relationship is physical, and there's nothing wrong with that. But you know, it is individualized what I say to the person in front of me. I take into account, you know, what type of procedure they had, were their nerves spared, what kind of erectile function they had prior to the procedure, and then what are their goals with regards to their relationship. We take in all those different factors and then we apply what our counseling is. You know, if you don't have good erections before the procedure, probably not going to come back. I mean, nobody's going to get better erections after they have the prostate out. Now, if you have perfect erections, then it goes to the next thing, which is age. The younger you are when you have the prostate procedure, you are more likely. So if you're in your 50s, someone who's in their 50s who gets a prostate procedure had good erections is going to recover their erection better than someone who's like 65 to 70 who had perfect erections beforehand and underwent the procedure. You got to take into account if they have high blood pressure, diabetes, other issues that may lead to erectile dysfunction and prevent them from recovering and their nerve regrowth. So unfortunately, it's not a simple answer to say like when exactly or to predict. The general information is that if you have good erections, you have about a year and a half to get back your erections with help. It's not just by themselves, it's with help. It's with essentially tadalafil or Viagra. So you need to use that as you're recovering. And then some people are able to come off it, some people are not. However, if you're dissatisfied with your therapy and you're at a year and you're like, now's the time, it's unlikely after a year that you are actually, if you had no action down there and it's not even getting partial erections, that you're going to recover. If you just keep on waiting, nothing's working with the pills, you got to move on. I mean, it's just one of those things where if you need someone to say to you, move on, I'm saying it right now. It's sort of like you have to direct what's important in your quality of life and make that known to whoever's seeing you and make them address that. And so if they say, hey, no, it's way too early, wait, you have to be okay with it or find someone who will do what you want. When it comes to erectile dysfunction and the urinary leakage, you guys, I say this to all my patients, like, you guys are the captains. I'm the first mate. I can tell you where to go, but I can't make the decision on what direction to choose. I can tell you which directions you can go in, but ultimately that direction of what you choose is you, because I'm not at home with you guys when you're living your life. That's a decision for you to make for your own quality of life. Only you can define that. So that's really where I come from. Some other people may take a different road and approach in counseling, but it's pretty close to that for most sexual medicine therapists.
Alrighty. Next question here, which I thought was a pretty good one. We're going to have time for about one or two more, but this one is, can sperm be harvested after prostate removal?
Sperm can be prostated after removal. That's my other thing I did in my fellowship is reproductive medicine. And so you are continually making sperm from your testicles, and they go into your vas deferens, which is where you get your vasectomy, and it goes all the way out to the seminal vesicle. The seminal vesicle sits behind the prostate. That's removed at the time of your prostate procedure. So usually the testicles are still producing sperm. Now, depending on what age you are, the health of that sperm may decline as you age. However, there's plenty of people that can still father children, 50s, 60s, 70s. It's just a lowered chance over time. If you're on like testosterone replacement therapy, chance of harvesting sperm is essentially zero, because that will affect your fertility pathway. If you receive radiation or hormone therapy to cut your PSA level down, which basically puts your testosterone down to zero, your fertility will suffer for those reasons as well. So if you are 50s and you get your prostate out and you still want to father children or you want to harvest your sperm, you can do that.
Wow.
Alrighty, perfect. I think this is an interesting question, but I guess what, if anything, can someone do to keep their PSA low, at zero or below, they say, but I guess just as a general wrap-up question, what can people do lifestyle-wise to maintain their prostate health?
So great question. There's multiple things. What it really comes down to is good diet and exercise. I think everybody understands that what good diet and exercise is, but it may be hard to do. There are thoughts that there's something called phytoestrogens. There's some supplements. There's things that can help shrink the prostate. Usually, when it comes to prostate health, there's two different things. Is it prostate enlargement or is it prostate cancer? Because the prostate enlarges and causes urinary issues. That's one thing with prostate growth. And then prostates can develop prostate cancer. Now, prostate cancer can be hereditary, can be higher risk if either your brother or your father, or some first degree relative has prostate cancer. That can increase your risk of having prostate cancer. People who are Black race can have an effect on prostate cancer development, and so can age. Generally, if you have a general healthy diet, that is the predominant recommendation, but you have to do it for years ahead of time to decrease the inflammation in your body, because inflammation, we think, is one of the key risks to developing prostate cancer. Now, there is a prostate cancer prevention trial that was published in the 90s that has the use of finasteride, which is something that can shrink your prostate, and they found that some men will have decreased risk of developing prostate cancer, but it's really the low risk prostate cancers. The high risk prostate cancers may occur regardless, but the lower risk prostate cancers may be prevented by the use of finasteride. We also found that maybe testosterone actually may have some protective benefit. Now that testosterone use, that issue has not been panned out quite yet. But they did find people who have lowered testosterone levels at the time of presentation may have higher degrees of prostate cancer. That by no means means that you should go and do testosterone, especially if you don't need it, as a means to prevent prostate cancer, because prostate cancer is generally under the control of testosterone. Now, if you're going from a low normal to a higher number, usually that doesn't create a risk for prostate cancer. I don't think testosterone leads to prostate cancer growth, unless it's a really specific situation, which is extremely uncommon now. So I know that's a little bit of a tangent, but generally a good diet and exercise and keeping the body at a general lower level of inflammation, which can be difficult in a Western diet, those things would have the best effect on keeping your PSA low.
If you'd like to learn more about surgical options and see which one might be best for you, you can do this by going to Coloplast. You can also do this by going to menmd.com. We have links directly to Coloplast from there. So you can navigate to either the ED or Incontinence pages on MenMD, or you can go to Coloplast, and I'm sure that they have a link right there on their homepage. If you have a question and would like to speak to someone in person, and if your question wasn't answered tonight, rather, you can also call MenMD at 857-233-5837. And this next one is also a perk for MenMD members, but you can log into the password-protected portal to schedule an appointment and have your question answered one-on-one with a personal health assistant. There will also be more resources in the Resource Center on menmd.com, so you can visit this page to view instructional videos, guides, expert articles, and more about all the treatments and conditions we just discussed.
If you found this video helpful and want to stay in the loop with our growing men's health community, be sure to subscribe to our channel and click the bell to be notified when new content is available. Your support makes it easier for other men like you to find these helpful resources. Thanks again for watching. We hope to see you again.